There we go. Okay. Hopefully everybody can see. All right. So again, great to be here today. I'm going to focus mostly on some of these questions that came up about, how do I know when it's the right time to treat? What kind of treatment should we be using, and kind of walk you guys through my thought process as a medical oncologist, where I'm seeing patients with EHE, and we're talking about what the right steps are for your disease. And so I again want to echo that Dr. Rubin's talk was a fantastic foundation and really covered the whole range. So hopefully we'll be able to dive into some of those questions that had come up with more particulars on the treatment and the course. So again, just a few highlights that were already touched on, but when I'm meeting a patient in my clinic, these are some of the things we talk about. Obviously the rarity, looking and trying to know the patient, like what is it about you that we can learn from about why this disease might have happened. I get a lot of questions about that. So again, more common in women overall, and middle age is probably the most common, the common age distribution. And again, as we've heard already, these diseases are incredibly variable, and it doesn't necessarily always go with what it looks like under the microscope. So the key things that we want to do in our cancer center and wherever you're getting treated are, before you make any decisions about treatment, first and foremost, confirm the pathology, make sure that we're actually dealing with an EHE. Because as we heard, there's a bunch of different mimickers, and treatment is wildly different, as is prognosis. We want to learn as much as we can about the EHE itself. So the actual tumor, what is it doing? Is it growing? And where is it? And again, this is just sort of some figures showing the distribution that Dr. Rubin already touched on. Is it only in the lungs? Is it in the liver? Is it in the bones? So we learn as much as we can here through scans and that sort of thing. And then the last piece is to really get to know you, get to know the patient, the host where this tumor is hanging out. We look at genetic background, we look at your immune system, we look at other medical conditions, and most importantly, we look at your symptoms. Do you have any idea that there's something going on in your body, or do you feel just as well as you always have? And so all of those things go into my bucket and my toolkit when I'm trying to decide what to recommend for treatment to a patient. So I thought for my talk today, I was going to build it around you guys. And so, I see a lot of EHE patients. I've worked with the foundation now for quite a few years, and everyone's been so, thoughtful as far as encouraging patients to come and talk to me. So at our center, I think in the last 3 or 4 years, I've seen about 40 people either in consultation or following with treatment. So I picked sort of some key representative stories to illustrate some of the points that we've been talking about today. And so, if you've seen my other talks that I've done, I talk about EHE patients as really being like snowflakes, because there really aren't two patients with EHE that are exactly the same. But some of them have patterns. And so the next couple of cases I'm going to show you try to illustrate that idea. So my first snowflake is a 45-year-old lady who, again, had a CAT scan for sort of this vague left upper quadrant abdominal pain. So a scan for something else. And lo and behold, she was found to have a pretty classic story for EHE, which is countless. This word is terrifying on radiology reports, but we actually see it quite a bit with EHE. Innumerable, meaning too many nodules to count in the lungs, but overall very, very, very small, less than 2 centimeters in size. And then they also noted the appearance of lesions in the liver. So here's a CAT scan showing the liver in cross-section, and you'll see these dark circles. These are cystic lesions, which mean they look like they're filled with fluid. And this is one way that EHE can appear in the liver. And so this was how they diagnosed this, got a biopsy, sticking a needle into one of these lesions that came back as EHE, which was confirmed with fusion testing and all those good pathologic things that Dr. Rubin talked about. And then she had scans 6 months later that showed absolutely no growth in any of those lesions. So these were here, they metastasized at some point for reasons we have yet to understand, but then they stopped. And that's sort of one of the classic patterns with EHE. So the take home, as we heard, patients can have stable disease, this sort of stable period of EHE. And 5-year survival with this disease is greater than 80%. And there are patients who have literally lived without progression for years. I think, up to 30 years. You guys have probably met some patients on the Facebook groups where, they've been living with this disease for a really long time. Most, but not all, patients will eventually convert to a more aggressive state. And maybe that is because of this genetic evolution that Dr. Rubin was talking about. Something happens, whether it's in the tumor or something about the host, that upsets the balance and the disease starts to grow more aggressively. There are a few case reports out there of spontaneous regression. Again, these are few and far between and poorly understood. But again, it's a really unusual disease. And when we start looking at the whys this happens or what causes patients to progress, we really need to do more work understanding things like hormones, estrogen in particular, given female predominance. There are some women that are diagnosed either closely before or after or during pregnancy, a huge estrogen load. So how does this play in? Inflammation and immunity. This is my area of interest, the immune system and how it interacts with cancer. And so I'll talk about a couple of things a little bit later in the talk, but this is all stuff we need to figure out. So anyways, the treatment plan for this snowflake lady was none. We were just going to do surveillance and save our treatments, which are not curative, for growth. And we touched a little bit about this liver-directed therapy idea. So this is sort of the one thing that sometimes we will talk about in patients that are stable, particularly if they only have liver EHE. Transplantation, I was always pretty reluctant to go there, but I've seen a few talks lately although not prospective data, but at least retrospective data showing pretty decent response rates. So meaning that 27% of patients have their disease and get cured and at least not go away or, go away much more than we would expect with other types of treatment. But the thing to remember about transplant, if you get someone else's organ, we have to shut down your immune system to keep it from rejecting someone else's organ because there's that mismatch. And when you do that, number one, your immune system, whatever it's doing in EHE or for other things, is now suppressed. It's never going to be normal, and you have to stay on that forever. And the second thing is that can keep you off of clinical trials down the road. So if you do a transplant and it's not curative and the disease comes back, we may be stuck in a situation where you're not able to participate in some of these trials because of the ways that, we look for safety and other things. So the other thing we've been doing more of in the setting of stable disease or with 1 or 2 liver lesions starting to grow are directed therapies at those lesions in the liver. And IRE is electroporation or something called nanoknife. And I think many of you guys have heard about Dr. Raj Narayanan and others in the country, in the United States at least, that are doing nanoknife therapies for liver lesions. So I've had a few patients where if 1 or 2 things in the liver are progressing, we've been able to avoid systemic treatment simply by going after those lesions. So something to keep in mind. All right, next snowflake, the more aggressive picture. So this patient of mine, 55-year-old gentleman who came in with back pain and had disease, multiple bone lesions in the spine, and also in other places in the bone based on a full body bone scan. They also found that he had inflammation in the lungs that was concerning for pleural involvement. So remember, pleural is the lining of the lungs. So as Dr. Rubin talked about, this cocktail, this pleural and bone involvement is usually a sign of pretty rapid progression. Not always. I met a patient not too long ago with pleural disease that did really, really well with treatment. So it can be reversed and it can be fixed, but this is usually for me a sign, okay, we need to jump on some kind of treatment very quickly, assuming that the patient is strong enough to handle that treatment. You do always want to make sure you don't have angiosarcoma, again, by doing the fusion testing, particularly in pleural and bone, because angio definitely loves to go here as well. But for most patients with this picture, we're reaching towards stronger chemotherapies, which again are not perfect for EHE, but we're trying to get some sort of control of the disease. And often there's hopefully genetic things that have happened that make the tumor more rapidly growing and hopefully more sensitive to traditional chemotherapy. And then my third snowflake I'll talk about, this lady was 50 years old and she had actually had right arm weakness for many years and sort of blamed it on shoulder issues, maybe rotator cuff injury, but ultimately wound up getting scans that showed a large axillary mass. So this is the armpit. In this MR, this is her shoulder out here, and it's sort of a front crossways section. So the bone of her shoulder, the bone of her arm is here. And then you can see this bright white glowing structure here. That's the EHE mass. And that was her main problem. She had 2 or 3 little tiny things in the lungs, but really this was the main issue. And biopsy was done, confirmed EHE, and this poor lady was really symptomatic. So a lot of pain and just weakness. She couldn't use her arm essentially. So, we went through all of the different options, and for her, we actually settled on a combination of targeted therapy, which are medications that block particular pathways that we think are important to EHE, as well as a little extra help from a traditional chemotherapy drug that has been packaged in soap droplets, so it's less toxic. So that's liposomal doxorubicin, or Doxil, that you guys might have heard of. And then we actually wound up doing radiation for her after she had been pre-treated and gotten some stability here. And she actually did pretty well. She tolerated the therapy well, and her pain had got to a point where it at least nearly resolved, and she had gotten a little bit of function back. So sometimes you need to reach for multiple things just to try to come at it from multiple angles for patients that are really the most symptomatic. So this is sort of the summary of the things I've just talked about. So if you only have one side of disease, think about trying to resect it if you can, and potentially ablation or liver transplant if it's liver only. And then we talked a little bit about surveillance scans to watch for other sites of disease. If it's all over, widely metastatic, and you can't do surgery, I typically will look for local treatments if there's only 1 or 2 or 3 areas that are growing and everything else is sitting there. But if it's all growing, I typically will go to widespread or to systemic treatment, so some sort of chemotherapy or targeted therapy. And then we scan when people are on treatment more often. And then clinical trials, of course, are always important. If there are trials available for EHE, this is the only way we're going to learn about new therapies, and I'll highlight a couple of these here in a little bit. So this is just a list of some of the systemic treatments that we've used for this disease. Again, they're rare. So most of this data is from case reports, series, low numbers of patients, centers that have treated a lot of these patients, as well as anecdotes, so experience from doctors. Unfortunately, most of these are stabilizing, and there's not a lot of long-term responses with the majority of these agents. This is why things like the registry are so important, is that, everybody's been treated, particularly internationally or in smaller centers, and we need to gather all of your experiences to increase our numbers and try to really get a sense of which treatments are the most effective. But these are just a list of targeted therapies here in the orange. Some of these block blood vessels. Trametinib, you just heard about from Dr. Rubin about blocking the MAP kinase pathway. And then mTOR inhibitors, these have been probably one of the most commonly used strategies based on a lot of work from Europe for patients that have been treated with these, and I go to these pretty often. Chemo is really, I reach for it much less often. So really, I'm typically reaching for these targeted therapies because they're a good balance of stabilizing, but also quality of life. This is the data for the trametinib. Again, this is going to come out and be published soon, and this is from 2021. But just to show you that we can actually do clinical trials for EHE patients, Dr. Schutze, Dr. Rubin, and others were able to enroll 41 patients with EHE, and they received trametinib, which is the MEK inhibitor pill, 2 milligrams once a day. And this was for patients at least 15 years old. And importantly, what the study did, in addition to looking at what the tumors or how the tumors changed, they also looked at how patients' pain and health have changed by something called patient-reported outcomes. So really, were patients feeling better as a result of treatment? This is what's called a waterfall plot. So this shows every bar represents a patient who was treated on the study, and then the change in the tumors. If the bar goes down, that means the tumors decrease by a certain percentage, 20%, 40%, and so on. And if it goes up, it increased. So even just looking at this, you can see that most patients had a very mild decrease in their tumor, and about 40% had stable disease for more than 6 months. So this is actually pretty promising that we could actually help patients with this disease. I don't have the data today, but patients also reported improvement in their pain and their ability to do their activities of daily living on the study. The side effects are not easy with this drug, but they're manageable. And as we get more experience using this is an option to think about. The immune system. So a lot of patients ask me about what I can do to boost my immune system to fight EHE. Should I get immune therapy, these treatments that boost the immune system to fight cancer, or is this applicable for EHE? So, if our immune system was doing what it was supposed to do all along, it's really good at preventing cancer. That we would all have a lot more cancer if our immune system wasn't functioning, which is why things that suppress your immune system are typically bad. And this idea of a cancer that sits there and doesn't grow. It's really tempting to imagine, well, my immune system is keeping it from getting out of control. And that's been reported in other types of cancer and other types of sarcomas. So, we don't know a lot about what the immune system does in the tumors, but there's a lot of stroma, which is that supportive structure. And in other types of cancer, that's really important for suppressing the immune system and regulating the immune system. There's some of these things like chemotherapy or some of these ablations in other types of cancer have been shown to cause damage signals that help your immune system go there and recognize there's a problem. So really interesting ideas for EHE. And there's a few patients out there who have gotten checkpoint inhibitors, which are one of the most commonly used types of immune therapy that have had benefit. But there are also patients that have not done well. So again, really, really early in this work. But what I have done here in Colorado is run a clinical trial combining traditional chemotherapy, Doxorubicin, with 2 immune boosting drugs, these checkpoint inhibitors. And we've completed the first part of the study, which is about 30 patients, give or take. And EHE was eligible, but unfortunately, we did not get any takers. We did not have patients who opted to participate in the study. So I can't tell you anything for EHE. We're going to present this data for overall for all sarcomas at ASCO. And there is an ongoing cohort, a new group of patients being treated right now with a next generation immune therapy drug called botensilimab that looks really promising. So again, this is not the right trial for everybody, but for rapidly progressing EHE that has not received chemo, specifically doxorubicin, this is something to think about. Okay, and then just before I wrap up there, I wanted to talk a little bit about the EHE pain syndrome because I spend most of my time in clinic talking about this. So really, we don't understand this and it's not very well described. And so everything I've listed here is what I've learned literally from all of you and from people that I've talked to in the community. But the idea is this is diffuse pain. Even if your EHE is stable, even if you don't have any EHE that we can really see, or it's very, very small amounts, and there's not a clear other cause that you can find on scan. So there's no bone disease, there's no mets somewhere else. But people have described this as muscle aches, joint pains, back pain, organ pain. So like pain in the abdomen, even with the liver disease not really being that progressive, people still really complain of this discomfort. The people also state lack of energy, depression, and mood changes, and even neurologic changes. I had a patient recently who's having numbness and tingling and weakness and just frozen joint syndromes. I mean, like really quite a problem. And so we think about this as maybe being like generalized inflammation from the body's reaction against having cancer, but that's really hard to prove. And we don't know what the chemicals are that would be driving this sort of thing. But what I do know is that my poor patients go to pain specialists or to other providers and they're labeled. They're labeled as drug seeking, or they're labeled as having psych issues. And there's nothing wrong. There's nothing wrong that we can see. So you must not really have all of this pain, but that's not true. EHE patients can struggle with pain. Again, not everybody, but it happens. I've found the most helpful things are anti-inflammatory strategies rather than traditional pain medications. So this is where celecoxib or Celebrex can come in and be very helpful for some patients. There's also probably some impact to slow the disease. Again, hard to prove, but if you believe some of the anecdotes out there, this can be quite helpful. I have several patients that have done quite well with steroids, which are a very potent anti-inflammatory. We don't like having people on steroids long-term, but I have a couple of people that's been the only thing that's held their EHE pain under control. So we really need more research here to try to understand how to help patients with this particular part of it. You can also treat the disease, and sometimes that can help. And the last thing I'll just mention is some patients swear their symptoms get way better with dietary changes and some supplements. This is tricky, again, to sort through, but this anti-inflammatory diet, what does that actually mean? But in general, more of a plant-based diet, avoiding processed foods, avoiding simple sugars seems to help some people. And you guys all will be a much better source for each other about what has helped and what hasn't helped. But I have seen people do better with this sort of strategy. All right, just to wrap it up. So we've already talked a lot about this. The EHE Foundation has done incredible work since I started taking care of patients about 10 years ago. We have grant funding, we have clinical trials, we have mouse models now. So I would just, again, echo everyone's encouragement to share your data if you're willing through the registry and then the biobank initiative so that we can continue to move this work forward. And then for any providers who are on the conference today, or if you go to see a provider who's not familiar with EHE, this is probably the most comprehensive, best guideline paper to share with them that kind of gives you everything they need to know about what we know about EHE, which again, not perfect, but at least the consensus from the people who have seen the most of this. So again, the take homes, super rare, everybody's variable. Know the specific tumor in front of you, know the patient in front of you, and then only reach for your treatments if you really have a compelling reason. Either the disease is obviously growing on scans or the symptoms need to be managed, whether it's diffuse EHE pain or more local problems from the tumor themselves. And so this is our past, present, and current sarcoma team at Colorado. You'll see some familiar faces, but I'm happy to take questions, and you can find me on Twitter, and emails are always welcome. So thank you.